Huge welcome, everyone. Good morning, good afternoon, depending where you're joining us from. A warm welcome from almost sunny Oxford this afternoon. It's my huge pleasure to welcome you to today's Engaging with Evidence session on a fresh off the press report on the Living Goods Results-Based Financing Program. We've got an amazing lineup of speakers joining us this afternoon and a really interesting discussion. So very much looking forward to the session, and many thanks to all of you for making the time to join us. I'm Andrea Anastasiou. I'm Exec Director at the Government Outcomes Lab. I'm seeing quite a few new names, new faces on the call. So if you're joining us for the first time, it's just worth mentioning that the Government Outcomes Lab is an academic center based at Oxford University. Our mission is to enable governments around the world to foster more effective partnerships with the private sector, with the voluntary sector, non-profit organizations, and so on. And we do so by conducting independent research on outcomes-based partnerships, but also by curating a suite of open access data sets, knowledge products, and also by making sure that we're connecting all the amazing practitioners and policymakers in the field. And that's very much the reason why we've launched back in 2021, the Engaging with Evidence series. Nikki, if you want to take us to the next slide. Again, if you're joining us for the first time, you might not be aware of this series. For us, it's our way to make sure that we're creating the bridges connecting policymakers, practitioners, and researchers around the world around the latest findings from the field, to make sure that evidence, and when I say evidence, I don't mean just evaluation work or research, I also mean the lived experience of practitioners. We want to make sure that all that evidence and depth of knowledge is actively used by practitioners and policymakers around the world in their program design, in funding decision, in policy decisions, and so on. So for us, the Engaging with Evidence series is a really important one, and I'm delighted that we're able to have this discussion today about the Living Goods Results-Based Financing Program. It's a really pioneering program. I really look forward to hearing more about the results, but I'm also looking forward to discussing with our guest panelists some of the deeper insights from the implementation, and in particular, some of the insights around the RBF financing mechanism itself, the impact of that, how it felt different, and what some of the impacts of using that particular funding mechanism has been. With our sessions, we love to bring together a really diverse mix of perspectives. So we've invited some of the key stakeholders involved directly in the implementation of the Living Goods program. So we're joined by Sarah from Living Goods, also by Nicole from Instiglio, and Paul from USAID. And alongside them, we've also invited a handful of other experts just to help us contextualize the findings and actually look beyond the individual results of this particular program and ask, what does this mean for the field? What does it mean for results-based financing? And what does it mean for the scope or the opportunities to use this kind of financing mechanisms for health and indeed other services? In part one, we will hear from Sarah and Nicole, who will give us an overview of the program, and we'll discuss the results and the key learnings from the Learning Agenda report. If you haven't seen the report yet, I know we've shared the link by email and on social media as well, but if you haven't seen the report, I will encourage you to read it. It's available on the Instiglio Publications webpage. It's also available on the event page where you would have signed up for today's session. And I'm sure one of my colleagues will add the link in the chat as well. And in the second part of the session, we'll host more of a panel discussion. We like the sessions to be as interactive as possible. So we'll have an open discussion with all our panelists to, as I said earlier, to have a bit more of an in-depth exploration of the key findings and the wider implications. One final thing, if we can move on to the next slide. I would absolutely love to know who we have with us on Zoom. I see people are still joining from the waiting room. So I want to invite all of us actually to take 1 minute, go to the Zoom chat and just say hi, introduce yourselves, and bonus points if you also share maybe one question that you hope to see addressed on the session, or perhaps the reason why you joined today. I can't promise that we will have time to get to all the questions that you might have, but I will certainly be keeping a very close eye on the chat throughout the session, and also feel free to use it to ask questions, share your own experience, share your reflections. From experience with previous engaging with evidence sessions, the discussions tend to be very animated in the chat as well as in the actual panel discussion. And sometimes I know our speakers try their hardest to pick up questions actually even directly in the chat. But I will stop throughout the session to see if there are any questions from our participants. And yeah, I think with that, we're ready to get started. If you can keep your camera on throughout, it's lovely to see everyone. I think it just makes the whole session feel more engaging, but you don't have to. And yeah, let's get started. So Sarah and Nicole, can I bring you in at this point? So Sarah, I think we're starting with you. And please do introduce yourselves briefly before you dive into the presentation.
Sure, great. So my name is Sarah Rizzo. I'm with Living Goods. I'm based in Washington, D.C. And so I was working closely with the Living Goods team based in Uganda, who were directly doing the day-to-day implementation of this project, as well as with the various partners and USAID and Deerfield, who were the two funders of this project. And then Nicole, do you want to introduce yourself real quickly?
Sure. Hi, everyone. My name is Nicole Flock. I'm Associate Partner at Instigio, and we have the pleasure to accompany Living Goods over the past 7 years as they were exploring results-based financing and to work together with all the partners on this exciting project.
Great. Thanks, Nicole. And then just to add to the resources that were referenced, as far as there's the learning agenda, but we've also just published the final report to the USAID's document clearinghouse. So if you want a little bit more detail about, it goes in more in depth on some of the challenges from the implementation perspective, as well as a little bit more on the evaluation methodology, things like that. You can check that out through the USAID document clearinghouse. But with that, I would like to start with introducing Living Goods so that you can understand a little bit more about the context and how this project was implemented. So next slide, please. So like I said, I'll give some background, then Nicole will share insights from the learning agenda and recommendations for going forward. Next slide. All right, great. So let me introduce Living Goods. So Living Goods is an organization with the mission to save lives by supporting digitally empowered community health workers to help often vulnerable and marginalized families get the care that they need. To do this, Living Goods implements what we call the DESK principles, both directly through our direct work with community health workers and in our partnerships with government. And so these DESK principles focus on making sure that community health workers are equipped with both the training and the essential medicines and resources that they need to carry out their duties. They need to be supervised to promote high performance, to ensure accountability, and to make sure that they have the support that they need and the guidance that they need as they're caring for the communities. And they need to be compensated as a valuable motivator for the community health workers, but also in recognition of the substantial time and financial resources that go into providing care for their communities. And then all of these three principles are supported by the fourth principle, which is that they need to be digitally enabled. So LG ensures that all community health workers we work with, be it directly or in partnership with government, are digitally equipped with a phone that hosts an mHealth application that the community health workers use when they're caring for the community. So this application serves as a job aid for community health workers by asking them guiding questions as they meet with community members and try to diagnose and treat or refer community members as needed based on the care that's required. The app also serves as a data collection tool. So in most cases, this data supports supervision, so providing supervisors insights into the activities that the community health workers are doing, maybe where they're facing some challenges. It also provides insights to local and national governments and supports forecasting for commodity planning. So making sure that the commodities, the medications and things like that are getting down to the community level by enabling some forecasting around that. But in this RBF project, it also provided the base data that was used for assessing Living Goods performance. Next slide. So this is just a quick overview of Living Good's overarching strategy for the work that we do. And we have a three-pronged approach to improving community health. And the RBF project tested a new approach in 6 of Living Good's learning sites. So this first column that you see there. And the idea was to evaluate its potential as a cost-effective model for really, improving the quality of community health. And then through advocacy and collaboration, Living Goods has also helped the government of Uganda to begin to see performance-based payments direct to community health workers as a potentially economically viable option for a previously all-volunteer workforce. So through this approach, we've also supported creation of that enabling environment and supporting with laying the groundwork for the potential to scale this approach. And this model was directly tested, or an RBF model that was paying for performance, was tested recently between a partnership with Living Goods and the local governments of Oyam. And it was also implemented temporarily during the second year of the COVID-19 pandemic, when for the first time the national government offered compensation for community health workers who were actively supporting pandemic efforts. So it's really exciting to see the progress that's been made around the utilization of potential performance payments in supporting really cash-strapped governments to be able to compensate these community health workers for the care that they're providing. So again, these are just some initial breakthroughs, but see a lot of potential in the future. Next slide. So how did we get to this point? How did we end up doing an RBF? So Living Good's approach, including those desk principles that I mentioned, had already been shown to have substantial positive impact in the communities that we work. So for example, an RCT on our work in 2014 showed a 27% reduction in child mortality. And a new recently released RCT that was just released earlier this year focused on our work at scale. So our work with 4,500 community health workers, and it found a 28 to 30% reduction in child mortality. Likewise, we've done a study with Gavi on our immunization work that found improvements of full immunization by 36% in Uganda, and a reduction in zero-dose cases by 47% in the communities that we served. So really exciting results. And so what we wanted to do was, given this proven impact, we wanted to test a model that could also show cost effectiveness, with the goal of seeing how we might be able to scale our proven approach with both government or other donors and partners. Thus, in 2018, we piloted an RBF with funding from Deerfield, still in partnership with IPA and Instiglio, in 2 districts in Uganda. So this RBF provided payments to LG based on the verified data of the community health workers we support. This 1-year pilot proved successful in both stoking the interest of the Ugandan government in performance-based payment and showing positive performance. Though all of the outcome funds were secured by Living Goods, we observed a substantial overperformance on certain metrics and underperformance on others. And these metrics are tied to specific types of care that are being provided to the community. So in an effort to control for this, when we designed the scale up with USAID DIV, the model was adapted to include a variety of controls to help influence the metrics or services being provided by the community health workers, and to add some more elements of quality into the approach so that we could make sure that we were really getting quality outcomes for the project. So with that, let me hand it over to Nicole to go more in depth about our learnings.
Thank you, Sarah. And we will start with a short overview of the design of the results-based financing mechanism. Sarah was mentioning the 2 main objectives for the scale-up program. We are to really drive improved cost effectiveness of maternal and child health services delivered by Living Goods. And to do so, and building on the lessons from the RBF pilot, the RBF mechanism increased performance targets over time and created a really strong incentive for Living Goods to meet targets by improving the productivity of community health workers. That is the number of results that were delivered by pair community health worker, as opposed to, for example, recruiting more community health workers in an effort to meet the performance targets. In addition, the RBF was also implemented over a longer period of time, 27 months compared to the 12 months of the RBF pilot, in order to provide sufficient time for Living Goods to use data and learn from implementation and make adaptations in order to improve productivity and cost effectiveness. The second objective was to really test how the RBF mechanism could place greater emphasis on the quality of service delivery and thereby, for example, mitigating the potential risk that a focus on quantity could provide in terms of neglecting quality in favor of quantity. The other two objectives for the program included to crowd in more funding from additional outcome payers for the RBF mechanism, which is the reason why the RBF was set up as an outcomes fund. And fourthly, to also leverage the RBF and the lessons to drive greater government engagement on community health, as well as results-based financing specifically, and potentially foster the eventual uptake of RBF by the government. Next slide. So as I mentioned, the RBF was structured as an outcomes fund in order to facilitate the participation of additional outcome payers while streamlining the contracting relationship among the different partners. Global Development Incubator acted as a trustee that pooled the funding from the outcome payers, USAID, DIF, and the Deerfield Foundation, and they entered into an outcome payment agreement with Living Goods. Living Goods then, as Sarah mentioned, reported on the results that were achieved by the community health workers on a bi-weekly basis. And Innovation for Poverty Action acted as an independent verifier that would verify a sample of the results reported by Living Goods through phone calls and household visits. And Instigio's role in the project was to support the design of the RBF mechanism, as well as to provide some ongoing program management support. Next, please. So here we can see a summary of the RBF design. As I mentioned, it had both elements of quantity as well as quality. So for quantity, the design included 9 metrics that comprehensively captured the results that community health workers deliver across 4 main health areas: maternal health, newborns, children under 5, and family planning. So for example, for maternal health, this included pregnancy visits for expectant mothers, as well as higher level outcomes, such as the number of antenatal care visits a pregnant woman completes at a health facility, as well as the number of women who deliver in a health facility. For children under 5, this included assessments of children under 5 with symptoms of cough, cold, diarrhea, or any other danger signs. And then subsequent treatment or referral of those children to health facilities. And community health workers also followed up on children who have not received the required immunization. And the RBF also paid for every follow-up that was effective in the sense of encouraging the mother and the child to go to the health facility and get immunized. For each of these, we'll go back to the previous slide, yes. So for each of these results, targets were established considering Living Goods' baseline performance, as well as the expected room for improvement on those results. And we calibrated the relative prices for the 9 quantity matrix, considering 2 factors. One, the level of effort of community health workers to deliver those results. And second, the expected impact on child and maternal mortality. Overall, the expected payment for the quantity matrix amounted to approximately 90% of the total expected payment. In addition, for quality, we developed 3 quality matrix with Living Goods and with IPA. The first one was client knowledge, which captures essentially how effective community health workers are in transmitting essential knowledge to clients. For example, for an under 5 sick child assessment, The quality metric might measure clients' knowledge of the causes of malaria, how to prevent malaria, typical symptoms, and what to do in case a child presents these symptoms. The second quality metric was client satisfaction, which measures how the client perceives the quality of services provided. And the survey here probed on areas such as empathy, honesty, respect, confidentiality, and overall satisfaction. The last metric, for both of these first two metrics, these were measured through surveys that were directly administered by Innovation for Poverty Action on an ongoing basis. We measured them similar to the quantity matrix on a quarterly timeline. And for the last quality metric, this was community health worker competence, which essentially evaluated the pass rate of community health workers on an annual recertification exam that Living Goods administers and that covers technical and soft skills. And this metric was measured on an annual basis. The payment for those metrics, for the quality matrix, was linked to the payment on quantity matrix. This meant that meeting the targets across all of these quality metrics would increase Living Goods payments by 10%. Performance above the target could unlock an additional payment of up to 15%, whereas performance below the target implied a lower payment and could even result in a reduction of the payments on quantity matrix by up to 21%. And in addition to those quality metrics, we also tested different quality safeguards. And those included overall coverage of community health workers, which measured the number of unique households that the community health worker covered in a given quarter, the supervision of community health workers, as well as additional effectiveness measures that looked at the percentage of pregnant women who delivered in a health facility or the percentage of newborns who received a postnatal care visit within 72 hours of birth. And there was no payment attached to those quality safeguards. However, Living Goods could incur a penalty if performance was below a minimum threshold that we established. Next slide. I think we'll skip this slide in the interest of time, but as Sarah mentioned, there were like a few additional design features that really aimed at providing very sharp incentives to Living Goods to really zoom into some results and improve their performance on some of the results based on the learnings from the RBF pilot. Next slide, please. So this provides an overview of the key results that were achieved during the RBF pilot. Scale up. In terms of community health worker productivity, Living Goods achieved 93% of the targets that were established. And as you can see on the top right, this you can see how this breaks down for like the visits that a community health worker does per quarter. So for example, on average, this means 8 pregnancy visits, 2 newborn visits within 27 hours, 62 under 5 sick child assessment, and 38 family planning visits. In terms of quality, Living Goods surpassed the targets that we established for client knowledge as well as client satisfaction. Unfortunately, we were not able to measure the community health worker competency on a regular basis. And then for the safeguards, those were, with exception of one safeguard in one quarter, Living Goods always surpassed the minimum thresholds that we established. Next slide, please. So we learned a lot during the implementation of the RBF pilot as well as the RBF scale up, and we want to highlight maybe some 3 key insights from the learning agenda, and then leave a few more maybe for the panel discussion. So coming back to the objective of cost effectiveness, and despite the overall strong performance in terms of achieving 93% on community health worker productivity, during the learning agenda, we did not see any evidence that the RBF actually led to measurable improvements in community health worker productivity. compared to performance prior to the result-based mechanism, or compared to performance in non-RBF districts where Living Goods operates. For the comparison between RBF and non-RBF districts, we conducted a trend analysis that compared the performance in these different district types, and we leveraged qualitative insights on potential external factors or other changes in the environment that might have affected performance differentially in those districts. But there was no measurable difference between RBF and non-RBF districts. One of the potential explanations for this is that there were positive spillover effects, and as we will indeed see later on for other insights, there were some of the changes that Living Goods implemented in response to the RBF incentives that were also implemented in other districts. Another really important explanation of why Living Goods only achieved 93% of the target for community health worker productivity, which is also equivalent to 97% of baseline performance, is the COVID-19 pandemic and the disruptions this caused to Living Goods operation. So the RBF was about to launch when the pandemic started, which resulted in disruptions to workflows, affected the training of community health workers and supervisors, and overall just drew Living Goods' attention to addressing really important other issues in that moment. After careful consideration and a short delay in launching the RBF stakeholders decided to go ahead with the RBF, despite the increased uncertainty caused by the pandemic. And the RBF design proved to be relatively adaptable to these new circumstances, because we had to only make small adjustments to it. Another key reason why we did not observe improvements on community health worker productivity is that initially during the first quarters, Living Goods' primary focus was on understanding and addressing the reasons for having a relatively high number of unverified results. And the core attention from Living Goods was on these areas, as we will see in the next insight. And lastly, another potential reason for why the RBF didn't have the intended impact on community health worker productivity is that we pursued multiple objectives, as I mentioned previously, and this resulted in a relatively complex RBF design that included many design features and drew attention to many different factors and areas of performance, potentially undermining a little bit the intention of providing a very strong focus on productivity. Next slide, please. With respect to the quality of service provision, as I mentioned previously, Living Goods exceeded the targets on client knowledge and client satisfaction, and for the safeguards, penalties were only triggered once for the in-facility safeguard indicator. However, during the learning agenda, it was really difficult to establish to what extent the strong performance on the quality matrix were attributable to the RBF incentive. Performance was very strong from the very beginning of the program, and there was limited room for further improvement. And one of the reasons why performance on those quality matrix was potentially very strong is how the quantity matrix were verified in the RBF. So the quantity matrix the verification protocol didn't just ask whether a result was achieved, but it also probed on other areas to see whether the client recalled some of the topics that were covered by the community health worker, meaning that the verification of the quantity results already included a small element of quality. So one recommendation that comes out of this experience is that the RBF mechanism, if it includes both quantity and quality metrics, to try to further more clearly disentangle these two aspects of performance, which would give us better insights into these two aspects of service provision, and also would help us better to understand to what extent the RBF incentives were effective or not, and to what extent the quality measures were also the right one and are the most suitable for an RBF mechanism. Next slide. Then lastly, the third insight is around the impact the RBF had on the quality of programmatic data. And here we observed, and there's very strong evidence that the RBF mechanism, and specifically the rigorous verification, led to measurable, scalable, and sustainable improvements in the quality of living goods programmatic data. At the start of the program, as you can see at the bottom left, there was a very high percentage of results reported by living goods that could not be verified by Innovation for Poverty Action. One reason is what I already mentioned, that the verification was designed in a way that didn't just capture whether the results was delivered, but also captured some elements of quality. But other reasons included challenges with the mobile app and workflows, as well as knowledge gaps among the community health workers, which led to the reporting of inaccurate results, which the verification mechanism picked up on and really surfaced. Given the importance of accurate data for living goods performance management approach and also the implications this had on payments, Living Goods invested significant time and resources to understand the causes of the high error rate and to resolve those issues. And you can see some of them on the right here, but essentially Living Goods implemented, for example, improved trainings and capacity building of community health workers. They implemented stricter penalties for community health workers and supervisors to motivate a stronger focus on data quality. And they updated workflows in the Smart Health app to resolve any challenges that cause the inaccuracy of reporting. Next slide. So here we captured some of the lessons learned and recommendations. And I think in the interest of time, I will just probably pick some of them. But the first one here is one of the key takeaways that we will probably discuss a little bit more during the panel discussion is that RBF mechanisms can really function as an incubator that enable organizations to identify and address challenges and generate efficiencies that can improve organizations' performance beyond a specific program. So as we have seen in the case of this RBF, the RBF surfaced like technology and data quality challenges, which ultimately really focus Living Goods' attention on those, allow them to problem solve them and to implement improvements and to also scale them to non-RBF branches. One of these additional, however, like I think those benefits need to be weighted against the potential cost that an RBF mechanism entails. And that brings us to the second key recommendation here, to basically invest more time in identifying potential improvements that can be made to reduce the cost of the verification mechanism, such as by leveraging existing technology, such as GPS mapping in order to better locate households during the verification process, or potentially relying on the implementers' data quality processes for the verification of results, with then just an independent audit of whether the implementers' processes are accurate. I think I will stop here because I see we are going a bit over time, to open it up for questions and to maybe pick up some of these other lessons and recommendations during the discussion.
That was brilliant, Nicole and Sarah. Thank you so much for such a thorough, comprehensive overview. And I know there's even more fascinating insights in the actual report. So another encouragement for everyone on the session to actually check out the report. So, and thank you for keeping to time. So we're actually doing okay. So we have a few minutes to pause for questions. And I saw a couple in the chats already. So I'm gonna perhaps get started with those. And do put your hand up, actually, if you want to ask your question live. Otherwise, I'll read some of the questions from the chat. And Sarah, early on, Amit, I think, was asking if you could give us a flavor as to what worked well and less well in terms of the implementation. What are some of the, I guess, key challenges, how they were overcome? And I suppose also it would be helpful to have your reflections on whether those both challenges and the things that worked well were as a result of the RBF mechanism, or you'd face those challenges into implementation regardless of the funding model.
Yeah, thanks. I think that's a great question. And I mentioned the report that we've just published in the USAID Document Clearinghouse. That'll be a great reference for if you want to know in depth. But at a high level, I think overlaid on this whole project was COVID-19. So we started the project around 6 months after the COVID-19 was formally announced as being a pandemic, right? So with that, especially when you're considering operations at the community level, there were a lot of changes in the way that we were working. We had to enlist no-touch protocols for a while. So the community health workers were still going. They were maybe making phone calls when possible to community members. It changed the way that service was being provided for a little while. Once we started to learn more, it turned to low-touch protocols, but all of these things have implications on the services that are being provided by community health workers. And given the integration of digital into the work that we do, they all had implications on those different workflows in the application, right? Like if you're no longer going to be doing a malaria test for a child, then that means that you need to be referring them to a facility if they're showing signs of likely having malaria. So there was changes in the prompts and things like that the application was giving. There was changes to the way that we were doing regular trainings and supervision. That all moved remote. So there was a lot of disruptions during this time that we were trying to kind of roll with the punches and figure out how we could change the way that Living Goods works to still enable these community health workers to provide care in their communities, even during this pandemic, without putting themselves or any of their community members at risk. So from that perspective, the RBF really was incredibly helpful in that the biweekly verification cycles that were going on provided us a lot of key insights. And I'll give an example. In one case, when community health workers had returned to full service provision, they were no longer enlisting those no-touch or low-touch protocols. The data from the RBF actually showed us that one of the workflows in the application was still incorrect. So it was still prompting community health workers to refer children who were showing any kind of symptoms for, malaria, diarrhea, pneumonia. But actually on the ground, those community health workers were able to treat those children. So that was causing an error rate in the verification because they were getting these prompts to refer and then continuous reminders to refer. So they were just marking them as complete because there was no need to refer because they had already been treated. So that was one thing that, it helped us identify that challenge really, really early on when you see like a high error rate on a specific metric like that. So in that way, it was very helpful during this, really abnormal situation. As far as challenges, I think there were several. Given what I said about how helpful it was during this abnormal situation, the data was really, really valuable, but because we were trying to keep this approach cost effective, the sampling, as Tabitha mentioned, there were 9 different metrics that we were looking at just for quantity, right? And then there was the quality metrics as well. And so the sample size was relatively small in these biweekly cycles, and it was spread across all 9 metrics. So it might be the case where we're not getting really any insights on things like immunization, on things like delivery at facilities. It takes it might take several quarters for us to even identify a trend there and then identify if there's a challenge. And then, some in-depth field engagement to try and understand the root cause of the challenge. So while this did help from a learning perspective, because that was not the original intention of this RBF approach, if an RBF was scoped to have a more of a learning perspective, a larger sample size that's more evenly spread across metrics would have been really, really helpful. Because the reality of it was we incurred a lot of additional unplanned costs as we were trying to understand some of these trends that we were seeing, given the need to really dig in deeper. So those are two things that I'll highlight. But again, the report shares a lot more about that experience.
That's brilliant. And cost and complexity, we'll come back to that in the panel discussion. But let's stay on metrics, because I saw a couple of other questions, and obviously metrics and outcomes measurement are at the heart of RBF mechanism. So I think it's worth exploring those questions. Before I do that though, Sarah, I think you've mentioned a USAID report that I've noticed a couple of people in the chat were asking for. So if you have the link handy, not necessarily right now, but maybe after the session, if you're happy to share that link with us, that would be really helpful. And we'll make sure to share it with everyone in the follow-up communications. But on metrics, there have been a couple of questions in the chat, and Sarah and Nicole, feel free to jump in. I should also say at this point that we also have Paul Hamlin from USAID on the line. So Paul, if you feel like you want to jump in at any point on these questions, let me know. So Sarah, just taking them in the order on my screen, a couple of questions around metrics. Falasha is asking whether the payments were tied to the verification results, and then given that the payments were tied to the verification results, were there any unintended effects as a result of this? And I think related, Mara and the GoLab team is asking whether the community health workers themselves were familiar with the payment mechanisms, and if so, which elements of it were particularly able to influence their behavior, if any. So, Sarah, are you happy to make a start at least on these two questions?
Sure, great. And I might actually ask Nicole to answer the first one. Nicole, if you feel comfortable with that.
Yeah, so the first one is indeed like a really interesting question of whether tying funding to results can create any perverse incentives. And I guess like one of the positive benefits of that relatively complex RBF design that we mentioned was that we really thoroughly aim to mitigate any potential perverse incentives. So following like also on the lessons of the RBF pilot, we made sure that, you know, the RBF would really capture the full range of services provided by community health workers to avoid drawing attention just to, for example, maternal health versus under 5 size assessment or, yeah. And in addition, we included the quality matrix to mitigate any potential perverse incentives to focus only on quantity instead of quality. And then some of the other design features that we included also aim to mitigate any potential perverse incentives to provide unnecessary visits. So we have, for example, matrix-specific caps that would limit the number of results that Living Goods would get paid for based on previous performance and what stakeholders thought would be a good or a maximum amount that they wanted to pay for. So the RBF design was calibrated in a way that we really mitigated potential perverse incentives. And hence, as we did the learning agenda and talked to community health workers, to supervisors, to Living Goods, did a bunch of data analysis, we did not observe any unintended consequences that played out during the RBF.
Thanks, Nicole. Sarah, do you want to add to that?
Sure. Well, I'll respond to the second question there around the CHW awareness of the payment metrics. And so the simple answer is yes. The community health workers were aware of the payment metrics. So we made sure that, well, so critically, I think it was already mentioned, but, you know, LG was paid for performance in this RBF approach, right? It was not the community health workers that were paid for performance on these metrics. So that's one thing that's really important to note. But we made sure that, you know, the CHWs, the CHW supervisors in these specific districts were well aware of what these metrics were that we were that our performance was being measured on in these districts. So, and through the community health worker, that mHealth app that I mentioned, community health workers can actually see their performance on different service provisions. So they can see the number of family planning visits they did, the number of, you know, newborn visits within 72 hours, all of those things. So they have a view into that. The challenge, I think, here in some cases was some of those conditionalities and additional controls that were put on the measurement of performance, along with something, oh, sorry, along with the quantity element that was included in verification of, or the quality element that was included in verification of some of the quantity metrics. And so I say that because let's say I'm a community health worker and I've provided, 5 family planning visits this month. But unfortunately, I had run out of commodities, so I couldn't provide the actual method to the last 3 clients because the supply chain issues that happened during COVID-19 and the ability to get those commodities in Uganda. So these visits were all completed, but when they were being verified, because that community member might have been, let's say, referred to the facility to get that method because I didn't have them on hand, something like that, it could be that those cases were unverified because I wasn't able to provide that method. So that's one example. There was a lot of cases where, there was under 5 sick assessments that went on, but let's say at the time, grandma was caring for the child. And so I was there, I was assessing the child when grandma was there, but then when the interview happens for verification, it's the mom who's on the phone. And maybe she doesn't remember exactly what the community, or she doesn't know what the community health worker talked about, things like that. So there would be times when the quality elements of verifying the quantity metrics would actually give, were basically really challenging for a community health worker to assess. And that would adjust the actual number of verified visits they were able to complete. Likewise, there were some caps and things like that that were being applied as this data was being processed. So some of those other things also influenced the ability of community health workers to use what they were seeing on their dashboard as direct indicators of how their performance was going to be viewed in the project. Really complicated answer, but I hope that makes sense.
That is immensely helpful. And I feel like with RBF, outcomes-based contracting model, that the devil's always in the details. So I think it's worth taking the time to understand some of the detail of how these programs actually work in practice, what it means for the beneficiaries, what it means for the people doing the work on the ground. So thank you for that really thorough response. Right, we were doing really well for time before. We're now slightly behind schedule. I have to apologize to our fantastic 4 additional panelists who've been waiting patiently. I'll invite them all in now. I'm sure one of my colleagues will spotlight them so we can see them. So alongside Sarah and Nicole, we'll be joined by GoLab's academic director, Mara Ivoldi, and also in his capacity as GoLab visiting fellow of practice, Jonathan Ink, who's also senior legal counsel at USAID, but he's joining this discussion as a GoLab visiting fellow of practice. We're also joined by Dorothy from the Financing Alliance for Health and Paul at USAID, the department who are actually involved in the Living Goods RBF Scale-Out program. So a big welcome to all of you. Thank you for bearing with me and apologies for being a bit late. I will ask each one of you to briefly introduce yourselves. And then we'll jump straight into the discussion. We've got about 40 minutes left together, which hopefully will be enough time to unpick some of the things that Sarah and Nicole picked up in the presentation. And there are 3 things in particular that we wanted to focus the discussion on. And some of those already popped up in the chat, which is reassuring. And then, keep sharing your questions if you have more. But the 3 key things we're keen to explore with our panelists are the different rationales that different stakeholders involved in an RBF might have, and also the importance of distinguishing between the sort of impact of the RBF mechanism itself versus the intervention. And I noticed in the chat there are almost like 2 types of questions and participants, those interested in sort of like health, community health services and understanding the impact of the delivery model itself. And unsurprisingly, given our role at the GoLab and the types of audiences we tend to attract, lots of participants actually interested in the RBF mechanism and the, I guess, added value of funding services through that mechanism. So that's one of the key things we're going to explore. We also want to look at the impact of the RBF mechanism on the quality of program data and the implications, sort of like complexity, cost balance with a sort of like much more granular data that we've heard Nicole described. And then finally, the impact of RBF on government engagement and the wider relevance for health financing. We had hoped to get someone from the government of Uganda on the session. Unfortunately, they weren't available, but our panelists will share some reflections on that. Right, so let's do a quick introduction. Jonathan, can I come to you first? Then Mara, Paul, and then Dorothy. So no particular order, just where I see you on the screen.
Great, yeah, it's good to be with you all. And I think you covered the introductions really well. I would just add that anything I say, any opinions I expressed are purely my own and not those of USAID or the US government, but happy to dive into some of those questions that you mentioned.
Thanks, Jonathan. Mara.
Hi all, I'm Mara Roldi. I'm the academic director at the Government Outcomes Lab. So I see many outcomes funds and impact bonds, and I'm looking forward to share our experience and related to the Living Goods one.
Thanks, Mara. Paul?
Hi, I'm Paul Hamlin from USAID. I work on the Development Innovation Ventures program, which was one of the funders of this RBF. I also had the privilege and luck of working on the Village Enterprise Development Impact Bond, which recently wrapped up as well. And so I have some experience from both of those. And as Jonathan said as well, the views I present today will be my personal professional views and not necessarily those of USAID or the US government, but I'm happy to share them. Thank you.
I appreciate you being on the panel with us, Paul. And Dorothy.
Hi, everyone. I'm Dorothy McGee. I work for Financing Alliance for Health. I'm here to share my experience in implementing different models of resource-based financing. Thank you.
Well, thank you. Right, so just let's dive straight in. Paul, I'd like to come to you first. A lot of the RBF outcomes-based contracting veterans would probably be a bit fed up by now of us at GoLab going on about the RBF or outcomes-based contracting impact, added value, and why that's important. But I know there are people on the session who are perhaps maybe like less familiar with some of the discussions in the field. So could you help unpack for us a bit more why it's so important to disentangle the impact of the intervention itself from the impact of the funding mechanism that's enabled the intervention to be provided in the first place?
Sure. Typically donors in the past historically have used generally a cost reimbursement type of mechanism where implementing parties or implementing partners are paid for the expenses that they incur to implement a program. Sometimes they are paid for the outputs, a conference or an event or a training. But really what we all want to be doing is driving away from that model towards a model where outcomes or ultimately impacts is really what we're paying for. And in that drive to reach outcomes and impacts as the primary focus and the thing that is driving everyone's behavior, we have lots of different ways to structure that. They're all sort of generically results-based financing. But they could be a contract that is cost reimbursement plus some kind of award fee, which is based upon the impacts or some other outcomes. It could be a fixed amount grant award, which is the standard form that USAID uses. It could be a results-based financing program, like in this case, or it could be a development impact bond or a social impact bond. So there's lots of tools in that kit of how we finance things. But yeah, those are absolutely just a financing mechanism. And the intervention or the innovation, which is the things that we look at, or the innovations, those are distinct and separate. And if we have a good evidence base that the intervention or the innovation works, then we're really just testing and playing with the models of how do we finance these things and where do the incentives lie, and who is bearing ultimately also the kind of performance and financial risk in these arrangements. And so this RBF, I think, added a lot to our knowledge of who bears the risk, what's the appropriate risk sharing, risk assumption, and how are we impacting the outcomes and the performance based upon the financing structure that we put into place. But yeah, they absolutely are they're connected, but they're distinct. And I'm glad you highlighted that, because that's one of the main takeaways for me personally and professionally, that interventions is one thing, but the financing structure is another. And they certainly are related, but we should be careful whenever we're looking at something like this or the Village Enterprise Development Impact Bond to say, oh, it was a success. You have to clarify what was a success. I think we all know that community health workers is a wonderful, very low cost, high impact intervention in the health field. And Living Goods does a very good job of that as well. But just because that's successful doesn't necessarily mean that the financing structure itself achieved all of the aims and goals that we wanted. Thank you.
That's brilliant. That's really helpful. Related but distinct. I really love that. I think I'm going to steal it. Mara, can I come to you next? My sense is that, not all RBF programs, if anything, like quite a few have such a robust learning and evaluation agenda that looks specifically at the unpicking the RBF impact from the impact of the intervention. Why is that? Why is this so challenging? And how might, I know, we have a lot of people on the session who might be thinking about their evaluation strategies for their own RBF programs. How might we go about designing programs and evaluations that speak to these questions and make this distinction?
Yeah, this is a very challenging thing to do. Many people are interested in understanding what is the added value of a particular financing mechanism. You might have a program that is effective, but is it worth the effort of going through all the measurement or the contracting and the monitoring? So I think is an important question from really like implementation and policy decisions. The difficulty is that the best way that we have to do an evaluation is to have a control group. And it's very difficult to control the funding mechanism. So once a program is implemented, what you observe is the effect of the intervention with the funding mechanism combined together. In order to disentangle it, what you need to do is trying to find situations, and they are rare but not impossible, where you can, for instance, hold the intervention, the program, and change how you fund it. For those who are familiar with the work that the GoLab does, for instance, we are part of an effort to evaluate the Life Chances Fund. And in this project, there are about 30 impact bonds. And in these 30, there are a handful of opportunities. We are focusing on a couple where we are able to hold the intervention constant. So for instance, in Kirklees, there is an intervention to support the people that are vulnerable and need multiple type of support. I don't go into detail, but the organization providing the service had been providing the service on a fee-for-service model and then switched to an RBF. The same intervention, the same way of working, and the only change was the funding mechanism. It's not ideal, it's sequential. So in the impact bond, there was a COVID complications, as Nicole and Sarah were saying, but there are other examples where you take a standardized program. We have one on mental health and employment. The individual placement and support is a standardized way to support people with severe mental health back in employment and independence. This is being provided using multiple funding mechanisms. In those cases, you can see when I find it with an impact bond, what's the difference compare to others. But when you have a bespoke program, that is when it's really, really challenging. And trying to do a before and after, or all the tricks of evaluators when you have a stage rollout. And so you might have a cohort and you roll out a particular program and you start in some area with the fee for service, and over time you expand and extend to a different mechanism. You can do a comparison with similar cohort over time, but it's really, really challenging because you can't randomize easily. And I think that the real trick in the evaluation that we see is articulating a clear theory of change of why you're using an RBF as separate from the intervention. So you might provide a particular support to community health workers, but what does the RBF add. And in this case, as I think it was Sarah presenting the slide on what are the objectives, and there are 4 different objectives, or Nicole. And when you have multiple objectives, it becomes difficult to do the evaluation, because then there are complications and layers, and it's very difficult to identify what is leading to what. But if a clear theory of change, for instance, oh, we are doing an RBF because by paying for result, or as close as possible as result, we facilitate collaboration across different partners. Then if you have a clear idea that what you want to create is collaboration through the RBF, you can then study if through the RBF you've seen more collaboration than before. But if you have 20 different goals that might conflict with one another, it becomes more difficult. So my key word of advice is, like, to researcher, find example when you have a counterfactual, but that doesn't help everybody. So practically have a very clear theory of change, try not to overcomplicate, so that you can disentangle if that particular mechanism was at play better with the RBF mechanism compared to traditional mechanism.
Thanks, Mara. And in the spirit of being constructive, if I just may add to that challenge of evaluations and how to overcome them, there's also a wealth of evaluations now sort of like being published or in the pipeline around RBF program, outcomes-based contracts, and so on. So I think it's also really valuable to look at what others have done and draw inspiration from that. But yeah, Amara, I really liked your point about the fact that the added value of the mechanism and how we answer that question really depends on the rationales or the theories of stakeholders involved. And I suppose we shouldn't take it for granted that those objectives are always entirely aligned. And on that, I spotted a question from Jasper in the chat around the perspective of the outcome payers and the extent to which they use the outcome payment mechanism to choose between programs. So I think it'd be interesting, a question open to Nicole, Sarah, and Paul to understand a little bit more about the motivations of the different stakeholders involved in the program. And Sarah, I know you've already alluded to this and mentioned the sort of like scaling up, but Nicole, I guess I'm curious kind of how convergent the goals were at the start. Did you kind of start with a very clear theory of change? My suspicion is that the reality is a bit messier than that, but I'm curious to know what the experience was.
Yeah, I think it's a really interesting question. I do think we started with a relatively clear theory of change around using the RBF mechanism and as a way to draw attention to outcomes and to results, right? And provide a feedback loop to Living Goods that would enable them to adapt activities and services in a way that would drive greater cost effectiveness of the RBF. That was at the start, and I think the stakeholders were quite aligned around that objective, in addition to the second objective around the quality of service delivery that we can't forget about and that we want to understand how to actually measure and incentivize quality of service delivery. However, then I think what is interesting is that ultimately one of the objectives was also to think about scaling up, right? And how can those lessons and results be useful for governments as they are thinking about implementing community health worker programs? And that's where the theory of change wasn't that strong. Because of the previous two objectives, we really came up with this relatively complex RBF mechanism, right? Like really sharp incentives, highly incentivized environment for Living Goods, really trying to pressure them to like drive the last bits of like cost effectiveness in their model. But if you would think about how do you design an RBF mechanism that can be implemented at scale or that can be adopted by government, you would go in a very different direction. You would think about, okay, what is the capability of governments to implement those programs versus Living Goods who have very high capabilities, very performance driven, right? What can actually work at scale? And you would probably go for a much simpler design where you probably just say for the number of results that are achieved, maybe you don't even differentiate between the different results. Certainly you don't have probably like very different relative prices and matrix specific caps and several design quality matrix. So that's just like going back to Mara's point, I think it's really important to start saying, what are we trying to achieve in this mechanism? And to then the design of the mechanism will flow from there. right? And then later on, not coming back and saying, oh, but now it was very complex, it's not really suitable for government adoption. Well, at least like we didn't have a clear theory of change there at the beginning of designing the mechanism, right? Yeah.
Thanks, Nicole. So I think clarity in terms of theory of change, it's okay to have multiple goals as long as they're not conflicting goals, and thinking carefully through the implications in terms of how you then design the program, how you set up the, I guess, like working relationships, governance, and so on between partners. Sarah and Paul, would you like to add anything else to this question of the different rationales, I guess, from different perspectives to different types of stakeholders? It's Sarah, I think you might be muted. You don't have to. I'm just checking.
Sure. No, I'm happy to add. Can you hear me all right?
Yes, I can hear you now. Yeah.
Okay. Great. I'm happy to add just one note. I think, I mentioned the benefit to Living Goods a lot during COVID-19 of this specific project was around learnings, right? But there's balancing learnings versus, promoting performance and quality, reach, all of those different things. And then the other consideration is, with this project, Living Goods was paid for performance. So then there's also the differentiation between Living Goods performance or the implementing organization's performance versus the actual doers, which are the community health workers here. And so when we looked at performance, when Nicole shared that slide, it was looking at community health worker performance. The reality of it is Living Goods did drastically improve performance because we were facing all of these challenges. We were learning so much during COVID, all of these different things. And we did a lot of things better from our day-to-day, from our operations, our digital tool, all of those things were able to be improved to fit with the context during COVID. But that wasn't necessarily reflected in a high increase in performance of community health workers. So yeah, you've got to look at it in multiple dimensions. I guess that's the only thing I have to add.
Well, thanks, Sarah. Right, this point about complexity keeps coming out, and Jonathan, thank you so much for your very helpful points in the chat. I want to get reflections on these points about complexity. They're also a nice segue into the second topic we wanted to explore, which is data and what that looked like in the Living Goods RBF program. Is complexity inherent in RBF funding models? I noticed a question in the chat earlier talking about how we might simplify the model. Interested in reflections there, whether is that possible? If it is, why haven't we done it already? And then Jonathan, one of the points you made was that we need there's a need for a simpler RBF design. So perhaps I'll come to you first and ask you to elaborate on that point. And then also the point you make about evidence, I think it's an important one. So if you're happy to cover both in your contribution, that'd be great.
Yeah, no, happy to. And I think in terms of just quickly your question about is RBF inherently complex? It doesn't have to be, but the distinction is that the work we do in international development is inherently complex. And so making sure that we distinguish those aspects. Now on RBF design, I think it's essential that it's done as the most simplest form, at least in the beginning, and then we evolve over time to hopefully address some of the complexity for what we're trying to achieve. I think the challenge is that we end up getting in our own way by trying to make it the design super complex, because the issue we're trying to address is super complex. And then therefore we end up confusing everybody. And so I think Mara's points are well made in terms of RBF for what purpose and for whom needs to be clear. And I would go further to say, but the simpler you identify that up front, the better, such that you don't have so many goals that you can't also say whether or not you failed, because if success means anything, therefore it means nothing. In terms of complexity as well, which a lot of the comments are really good about kind of getting to the complexity of the design. I think part of it also is even simpler. It's what the language we're using, I think, is still a little bit scattered. Is it an approach? Is it a structure? Is it an instrument? Is it a mechanism? For me, I try to distinguish this by saying RBF, or pay for results, is an approach. You could have a structure such as an impact bond structure, and then you have an instrument, which could be, for example, the fixed amount award or the grant instrument itself. And then overlying all of that could be, design elements of how you design each of those components. But I think that's one way to kind of help maybe parse that out. In terms of the results-based financing as a tool, and that's a key point, is that sometimes that means it can be used well or not. And also it's not always appropriate depending on what you're trying to achieve. And so I'm actually not surprised by that first finding from the report that said RBF design in this case did not have any noticeable impact on the performance of the CHWs. I would think, however, that we don't necessarily conclude, therefore, RBF is bad in and of itself, or that it wasn't necessary for this program. It's just, to me, indicates that Living Goods has an established approach to how it conducts its intervention. It's good at doing that, and therefore it frankly probably did not matter how it got its funding. So if it got a cost reimbursement, traditional kind of grant, I would like to think the results from a performance of the intervention itself would be similar regardless. And so I think that would be one indication there. But RBF as a tool can also be used for purposes of easing administration of burdens for not only the service provider to manage the grant or the funding, but also for the funder itself. Because then on the funding side, we're not having to go back and verify each request for payment and ensure every cost is allowable. So there's also an ease of administration to an RBF design. And then lastly, in terms of the evidence piece, what I mean by that being distinct, if you think about it as a Venn diagram in a way, you have RBF design on one circle and then evidence on another circle. Sometimes it overlaps and sometimes it doesn't. So you could have RBF to ease administrative burdens where you're just paying on administrative milestones. Did you did you produce a report or did you not? There's no evidence involved in that component, that kind of milestone. But evidence, when it is incorporated in pay for results or RBF design, when I think it's done well, could be based on clearly defined outputs that have evidence for how that ties to the outcome you want to achieve. And so that would make for a smart RBF design for your outputs or your metrics or milestones in order to tie that to larger outcomes you hope to achieve.
That's brilliant. Thanks, Jonathan. So RBF doesn't equal evidence. I think that's an important point because I think often maybe that point doesn't get made quite so clearly, and outcome verification doesn't necessarily mean impact. So it's really important to think through very carefully how you're actually measuring the impact of an RBF program. And so you said it doesn't have to be complex, but it often is. So I guess my question is this added complexity worth it? And if we sort of try to simplify things, if that's the right word, what do we compromise? So I'm curious in particular in the context of data, because I know one of the things highlighted in the Agenda Learning report was that the RBF program led to measurable, scalable, and sustainable improvements, but that also in terms of the data and the quality of the programmatic data, but that came at a cost. So Sarah, perhaps I can come to you for this question. I'm curious as to your reflections from a Living Goods perspective. Was the sort of like additional complexity, cost, burden all worth it?
Sure. Thank you very much for that question. And I think, one thing that I already mentioned is, all of the community health workers that Living Goods works with are digitally enabled. So they have this application they're reporting in. So there was a base there already where we had data that was coming in from community health workers, and we were verifying it on a quarterly basis. We were doing a quarterly DQA process. So that there was a level of rigor that already existed in LG's work. I think really both the benefit and the challenge from this one came along with the frequency of review of that data, as well as some of the additional components that were included in verification for this RBF that maybe weren't included in the way that we had been doing our internal verification efforts. And so, you know, the fact that Living Goods was getting this data every 2 weeks, especially for those metrics that had much higher counts to them, so like under 5 sick assessments, there were a lot of those being reported. I mentioned earlier, you know, deliveries of facilities, less so harder to draw conclusions. But for those ones that were being more highly reported, if we were seeing higher error rates, you know, we were able to dig in deep and figure out what was going on. And so while there was definitely additional cost to that, given the uncertainty of the environment that we were operating in with COVID, it was well worth it from the organization's perspective, because as we learned, as we, you know, dug into these issues, we figured out what was going on. Those learnings, you know, we developed solutions to the challenges that we saw, and they were rolled out across our programs. It wasn't just in that one specific district, you know, assuming it was a broader issue and not just an, you know, a very, very, very contextual issue. It was rolled across everywhere. So it improved our performance throughout Uganda, and in some cases also in Kenya. I think really from LG's perspective, yes, this was worth it. I think there certainly were additional costs to us that were unintended, a fair amount of them, but it was because of our desire to be able to figure out, you know, where some of these error rate issues were coming from. Could it have been just as effective with maybe a simpler model? Yeah, I think so. We definitely could have made it somewhat simpler. But, you know, I do think it was a positive experience for Living Goods. And I'll also say, you know, as far as the complexity question that you asked, Jonathan, Living Goods' approach to working with community health workers is to pay those community health workers for performance. So it can be, you know, as simple as, you know, going out and serving their communities. We're getting that information through the app. We know that they were active this month, they get paid for that, you know? So there's all kinds of varying levels of complexity that you can add in, and especially when you're talking about working with government or other more resource-strapped implementers, I think there's a wide range of elements that can be included in the model to still encourage impact and yeah, promote cost effectiveness.
Well, thank you, Sarah. I saw an interesting question in the chat from JB. Mara, I might ask you to take that one in a moment. But before that, I want to come to Nicole and get your thoughts, Nicole, kind of given these complexities, but also benefits clearly of having such a thorough approach to data gathering and using it very proactively. What are your recommendations? You know, I know Instiglio has tons and tons of experience in designing and managing RBF program. What are your kind of key recommendations, or what should those on the session thinking about designing their own RBF programs take away from this discussion and all the points we've made about data and complexity?
That's an interesting question. I think just reiterating a couple of things. The first one, like really being clear, like what are you trying to achieve with the results-based financing mechanism, right? What's your fear of change of how it will deliver value to your organization? One of the insights is that Living Goods was already very performance-driven, very data-driven, has already like this like strong data focus to enable programmatic improvement. So maybe that's where RBF is not moving the needle that much, but I think that's not true for all organizations. And so when they are like put in this environment of having more data available and really drawing out performance insights and enabling course corrections and adaptations, maybe for another organization, this switch from a regular funding mechanism to an RBF mechanism can really drive a lot of the impact, right? For implementers, it's then important to really, I think also understand that like results-based financing does involve a greater risk for them, right? Because now their funding is tied to results. So really thinking carefully around how to set those performance targets is important to understand the risks involved.
Well, thanks, Nicole. I've just seen the time. So, Mara, I will ask you to perhaps, if you want, answer Jay's big question in the chats. We have just under 10 minutes left. And I also want to make sure that we spend a little bit of time also reflecting on the impact of RBF on government engagement, funders, prospective outcome funders, because that's such an important part of this ecosystem. So Dorothy, can I bring you into the discussion at this point? It'd be great to have your reflections on what is learning from this particular program and more generally from RBF means for the health financing sector.
Okay, I will start off by saying that ownership of the government is very critical in sustaining resource-based financing. And similar experience we had in Kenya when we were implementing the output-based financing program, where the government was a contracting agency for the voucher program. And sure to the word, because of the ownership, the government being in a position to develop policies that were favorable and ring-fencing money for that particular program, that resource-based financing program still exists 16 years down the line. So I think it's upon the host governments to take lead and in implementation of resource-based financing. They have a very big role to play in terms of sustainability and also mobilizing more domestic resources for the program. Another thing I would like to share is stakeholder engagement from the beginning. The more the stakeholders you engage, the more complex the resource-based financing usually becomes. And in terms of results, I'll say I have implemented resource-based financing for maternal and child health. And standard package at a point doesn't work. And I'd recommend this because for Uganda, I've looked at their data and I've seen that teenage pregnancy has really stagnated for the last over 20 years. And out of every 4 girls, 1 is pregnant. And probably we have been having this conversation as a country, asking ourselves, are the community health volunteers the most ideal people to generate demand for the adolescents? Could be that is a barrier that has not been identified. And when you're doing the evaluation in the end result, you're likely to feel like the community health workers did not contribute enough because of other barriers that were not picked the time you are designing the resource-based financing design. I think the other thing that I can talk about is the other social determinants of health. Because community health workers, their primary role is to prevent and promote. So I usually say the more they bring diarrhea to the health facilities, the more they refer more children with malaria, the more I get worried. I don't celebrate when they bring more diarrhea and more malaria because our ideal is for them to prevent the preventable conditions from occurring. But the other question is, how does RBF incentivize preventive and promotive services? I think that is a conversation governments are having on how to motivate community health volunteers to do more prevention than treating diarrhea and malaria and other, for example, chronic diseases that are really, we are really transitioning from communicable diseases to non-communicable diseases that are very expensive to manage in the sub-Saharan countries. Then I would like to say, but the bad experience that I have about resource-based financing is the risk of fraud, because every time you incentivize, then it means sometimes you attract fraud. And then the indicators that you usually attach an incentive, then now the other indicators are likely to be neglected. So in resource-based financing, I think it's good and fair enough for you to look at the risk analysis framework very well, and also to ensure that the community health volunteers are not branded MNH community health volunteers, yet the same population they are serving are dying of non-communicable diseases. So I think those are the risks that I've personally experienced, not forgetting about emphasizing on the role of private-public partnership, where we have had experience accrediting both private and public health facilities to support in strengthening the referral and linkage for community for health services. And this really created competition because in this particular program, we were issuing vouchers to clients. And once we issue the vouchers, they used to go to the health facilities without us determining the health facilities that they were to choose. So in the process, it was the mandate of the health facilities again to compete and improve services, the quality of services that they were providing to the clients for them to be incentivized. So I think the more innovative the result-based financing mechanism is, then the better for us. But sustainability for me is what carries the day.
I hate to interrupt you. I'm just mindful of time. Thank you for making those important points and underscoring the importance of preventative approach of investing in innovation and engaging with government stakeholders really early on. There's so much that we didn't get time to discuss, and I'm so sorry, but I hope that's just made you more determined to make the time and read the full report. Before we say goodbye, I would like to go to each one of our speakers. When we have time, we love to end this session asking our speakers to share one key takeaway that they want the participants from the session to take with them from this discussion. So I'll give 30 seconds to each one of our speakers to share their sort of like one key thought. If you take away one message from this session, what should it be? While they think about what they're going to say, I'm also just going to ask everyone, if you've enjoyed the session or even if you haven't, it would be lovely to have your feedback. I know no one really takes the time to do feedback surveys, so I'm just going to ask you to drop any messages if you found it helpful or not in the chat. And if you have any suggestions for us how to improve the sessions, what other topics to cover, possibly making them longer so that I don't feel under constant pressure that I need to cut people off. But with that, 30 seconds from each of our panelists with their key takeaway. And in the order on my screen, I'll go to Paul, Sarah, Nicole, then Mara, Dorothy, and Jonathan.
Thank you. Me personally, I'm a huge fan of any results-based financing mechanism, regardless of what form or structure it takes. However, I do caution that it's not always appropriate for every situation, and it's not always appropriate for every organization. There needs to be a very clear understanding of who is bearing what risks, and USAID with tens of billions of dollars can assume a lot of operational risk, but smaller implementing partners cannot and should not. Some interventions that are a little bit more untested and more innovative might not be appropriate for results-based financing, but innovations and interventions which have solid evidence base are probably much more appropriate. So I just leave you with those thoughts that RBF, I think they are the future, but they're not yet the only future for us. There's still a role for other traditional, cost reimbursement mechanisms given different parameters. So thank you all.
Great. And then from my side, from Living Goods as an implementer, I think one thing that I would recommend to anyone else who's thinking about an RBF is just be really, really careful to consider the environment and the context in which the RBF is being operated in, and really make sure that's very well considered into the design of the RBF model. I know that there was a lot of thought that went into this model, but even so, we found there was a lot of external challenges that we faced that we didn't have control over. So for example, connectivity for uploading data, for reaching some of the clients in verifying, certain things like that that hadn't been considered and wouldn't be the case at an RBF at a facility level, right? But then when you're taking it all the way down to the community, there's a lot more environmental factors that influence the project. So while it certainly did help LG improve performance during COVID, there's other things that if we were to implement an RBF going forward, I think we would certainly have some adaptations that we want to make sure we're integrated in.
I will keep it short. I will go back to what you said, Andrea. I think the devil is in the detail, right? And it's really important to start any design at the beginning with a thoughtful consideration of like how it will deliver value to the program stakeholders, and to consistently consider this in the design process.
Mara.
Oh, thank you. Sorry. My simple message is to focus on the why you are using a particular approach. And from that, various decisions will cascade on the design, on what you measure, on what you want to evaluate.
Sweet and short, I like it. Thanks, Mara. Dorothy, do you want to go next? Yeah.
Yes. For me, what I say is result-based financing comes in to support in our sorting challenges like accessibility, affordability, and equity. So I think in the long term, we have to look at this using a very much sectoral approach for us to sort out what are the key problems, what are the root causes, what are these injustices that are existing for the governments to support their beneficiaries to sort this out, because we'll just be going in circles. Yeah.
Thanks, Dorothy. Jonathan, last but not least.
Sure, yeah. One word, simplification. Simplifying RBF design will lead to greater adoption, and then we can improve upon that. So in short, if you're trying to submit a funding proposal, help the funders better define, price, and verify the milestones you are proposing. Don't let perfect be the enemy of good, but certainly, and also don't let good be the enemy of good enough. So.
That's brilliant. Thank you all so much. For 3 minutes over time. I do apologize, but I think it was worth every second. A huge thank you to our amazing audience. My mind is blown by the quality of the contributions and the questions in the chat, and it's just made the session so much more enjoyable. So thank you for that. And a huge thanks to our amazing speakers as well for taking time from their incredibly busy days to come and share insights and knowledge with us. I'm incredibly grateful. I really look forward to the next session. So if any of you on the line would like to suggest further topics, have questions for us, get in touch with us. We'd love to know what those are. But for now, it's goodbye from me, and thank you all very much. Bye.